Hello, everyone. Good afternoon to each and everyone that has joined us today for this session of perinatal and neonatal health of birth session series, the ninth one, and actually the last one of the year. So before we go ahead, kindly request that we have an opening prayer. Let me nominate one of us, Dr. Matthias Afari. You can lead us in an opening prayer. You have the right to unmute.
Thank you so much, Dr. Edbert. Help me confirm I'm being heard.
Yes, please, you are audible.
Okay, thank you so much. Let's pray and commit this meeting into the hands of God. Father, King of Glory, we want to thank you for this afternoon. Thank you for this important topic that we have gathered to share information. Lord God Almighty, we thank you for the people that have organized the ministry and collaboration with Global Seed Global. Thank you for everything that is going to be shared, Lord God Almighty. Thank you for your spirit, King of Glory. As we share, Lord, I pray that we will understand, King of Glory, what is being shared. I pray that more knowledge will be added unto us, that we may be able to manage our patients well, Lord God Almighty. To the glory of your name, I commit everyone that is going to share into your hands, Lord. Give them the boldness, give them the strength and the wisdom and the knowledge to articulate whatsoever that you have put in their hearts, whatsoever that they are prepared for the benefit of the public and for the benefit even of us, to the glory of your name. We pray all this in Jesus' name. Amen.
Amen. Thank you very much, Dr. Matthias, for that wonderful prayer. And once again, I welcome my fellow facilitators of the session today that are in the house here, and one is online. Then also I welcome you all the other participants who are online. I thank you all for sparing your time, your day. I know we're towards the Christmas and everyone is very busy, but thank you very much for taking this time off to join us. So today I'm called Dr. Nwamanya Edbert Bagasha. I'm your moderator for the session of today. And today we are going to discuss a very wonderful and amazing topic, which actually will enable us to manage our patients better, mainly the newborns. You know, these newborns usually come up with very subtle signs that if not understood, if not picked up by we, the health professionals, may not be able to actually manage these patients better, these babies better. And so that's why we are lined up a team that will help each and everyone in your different capacities and in your different health center levels, so that you can actually manage these patients. So starting from the midwife that receives this baby, actually the obstetrician who will deliver the baby, then the medical officer or the clinical officer will be called upon to manage this baby. Then the pediatrician and each and everyone that will be in contact with these babies, you should be able to understand these small subtle signs. For example, a scientific baby. So just about blue color discoloration, but there are very many things that this baby is telling us, and we should be able to always understand what they are trying to communicate to us so that we can actually manage them better. So today, I have a team of experts with me here. I think I'm going to allow each and everyone to introduce themselves and their different cadres and capacities that may not be able to explain to articulate better. So let me start with one on my immediate right.
Thank you so much, Dr. Nwamanya. Dr. Rona Gathanamonge, a pediatric senior house officer at Macquarie University.
Thank you. I think I can go to my immediate left.
Thank you, Dr. Edbert, and thank you, online audience. My name is Twali Baliku. I'm a consultant pediatric cardiologist at the Uganda Heart Institute. I also serve as a senior lecturer at the UCU School of Medicine in the Department of Pediatrics and Child Health. Thank you.
Okay, I think then after that we can go to the extreme left of the table.
Thank you, Dr. Nwamanya. My name is Cyanosed. I am a registered midwife and a neonatal nurse at Kampala Hospital. Thank you.
Yes, thank you, and you're welcome. Then we have our chat expert who is not with us physically, but is online with us already on the chat. Dr. Nora, I can please unmute and introduce yourself.
Good afternoon, everyone.
Good
Dr.
afternoon.
Dora Nampija. I'm a pediatric cardiologist and a senior lecturer at Bar University of Science and Technology. And I welcome everybody and our online audience. You're all welcome.
Thank you very much. That will be our chat expert who will be engaging each and everyone who will be online and via the chat call. So to start this session, we are going to start up with a sequence of events, which we'll start with a pre-test test, and this will enable us to understand where our knowledge levels are at the moment, assuming you get a child who is cyanotic, a newborn who is cyanotic. So after that, it will enable us to know where we shall have improved and or whether we may not have done a good job in teaching you or in trying to elaborate this topic. So I think it has already been displayed. You can start answering. You can check in on your chat and you'll see it being displayed. So I think let me just go through, let me read out for you. The first question is a 2-hour-old infant presents with central cyanosis, unresponsive to 100% oxygen. Preductal SpO2 is 85%, postductal SpO2 is 72%. Which condition best explains the findings? The options are there. Please answer. We have a short time to finish. We can move to the next question. Please answer, and I don't know, I hope everyone has so far answered who is on call. I hope you're actually able to see the questions, because we may find some of you are not able to see the questions. Yes, thank you. So let me read out the second question, but if you have not answered the first question, you can go back, read it, and then answer it. The second question, I'm seeing we are not seeing the questions. If you want to find the questions, you go to your can say right lower corner. You see that part of more, which has those dots, and then you can tap on the quiz. Usually it pops up if you're not able to see. Number 2, okay, thank you. Number 2, neonate presents with severe respiratory distress, cyanosis, and scaphoid abdomen. And a scaphoid abdomen is found immediately after delivery. What is the most likely diagnosis? Yes. I think you're seeing the questions and you're seeing the options for you to answer. Then the third question reads, a 2-hour-old term baby presents with central cyanosis, respiratory rate of 70 breaths per minute, SpO2 of 70% on room air. There is no mama, hyperoxia test shows a significant rise in SpO2. Which immediate intervention is most appropriate? I hope you are seeing the options there for you to answer. Please answer. It's okay if you are not sure, but it enables us to understand where you are not confident and where we should put more emphasis when we're explaining. Then number 4, our last question of the day is a term neonate presents with cyanosis, which improves significantly when crying, but worsens at rest. Which treatment is most appropriate while awaiting definitive evaluation? Yes, answer. That is our last question. There are 4 questions. Please, each and everyone who has logged on, if you have just logged on right now, we are already in the pre-test stage of the session today. you an answer and to enable us to know where to improve or to try to elaborate them more. And at the end of the session, we shall still have the same questions. And I hope if you find that there's a question you did not answer, by the end of the session, you should be able to answer it very well. And yes, I know that we have people who are going to come in asking for the CPD link. Yes, to come at the end of the session. So you can be patient, be attentive, listen in, and every question that is going to be asked will be answered. You can keep asking us questions via the chat. We have an expert who's there. And also, if you feel that you need more elaboration, someone to explain your question, the better, you will later raise up your hand and you direct it to one of us and we shall answer your question very well. So I think we have a few minutes, like a few seconds to go. Please answer if you have not answered. Yes, and by the way, if you have any expectation, I kindly request you to raise it up because you can find something unique that you need us to elaborate on. It's okay, you can raise up your hand if there's any unique expectation you wish that we can answer. You can answer. Yes, Nabanda Brenda, Nabanda, or what is the expectation for today's session? Okay, we are trying to work on our IT. It seems that it's a small challenge, but we can keep on sending your expectations on chat. Let me choose one other person to just give us their expectation of today's session. I'm seeing Agava Ronald. Agava Ronald, give us your expectation of today's session. What do you expect our experts to elaborate on? Thank you. We had a small technical glitch and we apologize. Hope now you can hear me. Hope you can hear me. I had called upon Mr. Agava Ronald to kindly unmute and give us one expectation of the session that you hope our experts can elaborate on. I'm still seeing the voice is lost. I hope you can all hear me. Yes, thank you, Godfrey, for confirming that you can hear me. So as I was still, yes, Ronald, you have raised up your hand. Please let us give you rights to unmute. Yes, Ronald Chang. You can unmute.
Good afternoon, everyone.
Good afternoon to you, Ronald.
I'm called Raymond. I'm a medical intern. Yes, I'm an intern. My expectation from this session is to be able to have a higher index of suspicion or to be able to clinically diagnose these cyanotic heart diseases. Heart defect, this is maybe something that is respiratory or something else, while I have limited resources in whatever center
Yes, thank you very much,
yeah.
Dr. Raymond.
That's
We
what
have heard
the
you.
clinical picture.
Yes, thank you very much, Dr. Raymond. Sorry, it seems we had one network, but I've heard your question. It's more about how to have a high index of suspicion so that you can come with a diagnosis in your low resource setting. Thank you, and I'm very sure that will be highly elaborated on, and our experts are going to be able to expound more on if you are in your health center 3 deep there in the village and you get such a case. So thank you each and everyone. Thank you for answering the pre-test, and I think we are good to go. And I expect that by the end of today's session, okay, I'm seeing Sepuya expectations on how to approach a baby in an emergency setting. Yes, we shall expound on that. Thank you very much, Dr. Sepuya. So as I was saying, we are going to start our session, which will start with a case presentation, so that we can have this thing in a practical setting. So Dr. Rona, sorry, I welcome you to take over.
Thank you so much, Dr. Nwamanya. Dr. Rona Gathanamoge, a senior health officer of pediatrics and child health at Makerere University, and I'm going to take us through the case. So this is a case of a 9-day-old male with cyanosis. So the patient was NR. He was a 9-day-old male. The next of kin was NA, who was the mother. They were from Balala Mukono. The child was Muganda by tribe and a Seventh-day Adventist by religion. The nearest health center was Mukono General Hospital. And the date of first visit to Kawempe National Referral was 27th of November, 2025. The presenting complaint was difficulty in breathing since birth and blue discoloration of lips, hands, and feet since birth. The history of presenting complaint: this was a 9-day-old male, referral from Kayunga Regional Referral Hospital for further management to Kawempe National Referral Hospital. The patient presented with a history of fast breathing since birth, associated with blue discoloration of lips, hands, and feet since birth. The child also had interrupted breastfeeding and excessive sweating while breastfeeding. However, the child did not have a history of body swelling or cough. He was delivered at term by spontaneous vertex delivery from Mukono General Hospital on the 19th of November 2025 with a birth weight of 3 kilograms. The mother had drainage of clear liquor 2 weeks prior to delivery, and she reported that the labor lasted about 13 hours. The baby did not cry immediately after birth and needed resuscitation. He did not breastfeed within the first hour after delivery and was admitted since birth. So he was admitted for 2 days in Mukono General Hospital and 7 days at Kayunga Regional Referral Hospital. Then the child was referred to Kawempe National Referral. The baby also developed yellow discoloration of skin and eyes on the 3rd day of life. In the antenatal history, the mother attended antenatal care 5 times. The first visit was at 3 months of gestation. She was given 3 doses of tetanus toxoid, iron tablets, Fancida, and mebendazole. She was tested for HIV and she was negative, and she had no history of chronic illnesses, for example, diabetes. She had no skin rash or history of torches during her pregnancy. Then she had no history of alcohol or drug use during pregnancy or herbicide exposure. she reported that she did an ultrasound scan at 4 months of gestation, which was normal. In the family history, this was the firstborn and there was no known familial illness. The mother was an 18-year-old who was a housewife. However, prior to the pregnancy, she reported that she was a housemaid. The father was 22 years old and he was a motorcycle rider. So in summary, I have presented NR, a 9-day-old who presented with history of blue discoloration of the lips, hands, and feet, and difficulty in breathing since delivery. He had interrupted breastfeeding and sweating while breastfeeding since birth. However, he had no cough or body swelling, and he developed jaundice at 3 days of age. He was delivered by spontaneous vertex delivery at term with a birth weight of 3 kilograms and needed resuscitation and birth. He was admitted since birth and was put on oxygen. Mother had drainage of liquor for 14 days prior to delivery, and the mother was 7 years old. My impression was cyanotic congenital heart disease in view of the blue discoloration of the lips and the hands and the feet since birth, and also the child had difficulty in breathing since birth. Well, the other things we're thinking of were congenital pulmonary airway malformation. However, the child's difficulty in breathing wasn't that marked, but it was among the differentials and also other congenital pulmonary airway malformations that the child can have. Then neonatal sepsis, since the mother had drainage of liquor for 2 weeks prior to delivery, and we're thinking of neonatal pneumonia. Then neonatal jaundice, because the child developed yellow discoloration of the skin at 3 days of age. And we're thinking this could be physiologic jaundice since it was the child developed the jaundice at 3 days of age, and also the breastfeeding jaundice since the child was not breastfeeding well. So on examination, this was a sick-looking term baby in obvious respiratory distress. He had central and peripheral cyanosis. He had no dysmorphic features. He had no pallor. He had jaundice tremor 4. He had no edema, and he was a febrile with a temperature of 36.9 degrees Celsius. His weight was 3 kilograms. His height was 50 centimeters, and the random blood sugar was 4.5 millimoles per liter. On respiratory exam, the child was in mild respiratory distress with a Silverman-Anderson score of 1 out of 10 because the child had intercostal recessions. The respiratory rate was 64 breaths per minute, which was tachypnic for this age. The child had bilateral equal air entry, bronchovesicular breath sounds, and he had no added sounds. And specifically, the child had no basal crepitations. The preductal saturation was 71%. On electric CPAP, and also the postductal saturation was 71%. Cardiovascular system, he had warm peripheries. The capillary fill time was less than 3 seconds. His heart sounds 1 and 2 were hard and normal. His pulse rate was 138 beats per minute. It was regular, normal volume, and synchronous. He had a machinery murmur at the left upper sternal border, and it was radiating to the back. In the CNS, he was alert. His anterior fontanelle was normotensive. He had a good suck, good motor, and grasp reflexes. And he also had normal tone. In the abdomen, it was of normal fullness. The umbilical stump was clean. The abdomen was soft. It was non-tender. The liver and the spleen were not palpable. And the bowel sounds were present. So our impression after the physical examination, we are still thinking this was a 9-day-old with cyanotic congenital heart disease, and specifically, we're thinking of the cyanotic congenital heart diseases that are duct dependent because they're the ones that usually present in the first days of life. And these include the transposition of the great arteries, in case the patient has tetralogy of Fallot with critical pulmonary stenosis. Yes, Then we were also thinking about parted ductus arteriosus because this patient had a machinery murmur at the left upper sternal border that was radiating to the back. We thought about persistent pulmonary hypertension. However, when we did the pre-duct and the post-ductal saturations, they were similar. There was 71%. There was no difference. There's no 10% difference. So that is why we dropped the differential. Then we are still thinking of congenital pulmonary airway malformation. However, the child's distress was not bad. Like we have seen, the Silverman-Anderson score for this child was 1 out of 10. And usually for congenital pulmonary airway malformations, the child's distress will be worse. And also when you give them oxygen, their saturations will greatly improve. But this patient was on CPAP and the saturation was actually 71%. So, neonatal jaundice, because the child had jaundice Crammer 5, then we also had neonatal sepsis. We still maintain the neonatal sepsis since the mother had a drainage of LIPA 14 days prior to delivery of this child. So the plan were to do a cardiac echo and a chest x-ray. We are going to see the results. However, the mother did not have money to do a chest x-ray, but we did the cardiac echo. We are to do a complete blood count, a liver function test, renal function test, and electrolytes. The child continued with the IV cefotaxime 300 milligrams BD for 5 days and the gentamicin 15 milligrams OD for 5 days. The mother was to breastfeed the baby. We started phototherapy. We continued with the CPAP at 6 centimeters of water, cord care, and keeping the baby warm. So this is the summary of the investigations that were done. The complete blood count was actually normal. The complete blood count was normal. The renal function tests were normal. Electrolytes were normal. LFTs were essentially normal. However, in the cardiac echo that was done on the 1st of December 2025, this child had detransphosphate arteries with pattern with an intact ventricular septum, a small pattern foramen oval, and moderate to large parted ductus arteriosus of 3 millimeters. So the follow-up, this was just the summary of the follow-up, but in short, on the 28th of November 2025, that's when we are to do the cardiac echo, and we've all seen the results. We are to do a chest x-ray, but like I've already alluded to, the mother did not have money to do the chest x-ray. We continued with the antibiotics, the mother continued breastfeeding the baby, and we continued with phototherapy. On the 1st of December 2025, when we got the cardiac echo results of the transposition of the great arteries, we weaned the child to free flow oxygen. The mother continued breastfeeding the baby. We stopped antibiotics, just like we've all seen, the septic markers were actually normal. Then on the 2nd of December 2025, we weaned the child to room air. The mother continued breastfeeding the baby. And on the 3rd of December 2025, we discharged the child through Uganda Heart Institute for balloon septostomy. Thank you so much.
What a wonderful presentation from our presenter of the day. I think we have all picked something from today's session, from the presentation. I kindly request if there are any questions that you wish that our presenter of the case would elaborate on, and you feel like it wasn't answered, or you want to air it out, kindly raise up your hand, then we shall allow you to unmute. I'm seeing someone has raised up their hand, has put it down. Anyone can raise up your hand, and if you feel like there's anything that needs to be elaborated on. I've seen someone ask what was the rationale of giving antibiotics in this session, so in this current case.
So the rationale of giving the antibiotics, like I've already alluded to, this is a patient where the mother had a drainage of life for 2 weeks to delivery. So this is a child who's at risk of sepsis, and that was the rationale of actually giving antibiotics to this child. Thank you.
Thank you. I think that is David, you have been answered. And then someone also asked, is there a possibility of coarctation of the aorta?
The possibility of the coarctation of the aorta, usually the coarctation of the aorta doesn't give you cyanosis, and actually the peripheral pulses were all normal. And in the coarctation of the aorta, usually the femoral pulse is not as strong as the radial pulse. And in our patient, actually, the pulses were all normal.
Thank you. I think we are good to go. Thank you, the presenter, for the session, for the case, and it was very elaborate. Okay, now let's move on to the next step. As you have heard from our doctor and how they have managed the case, I'm very sure it is pertinent for the nursing team, the midwifery team that usually is the backbone to treatment of these babies and these patients actually in general, to give us how best could a nurse help in management of such a baby, because we usually think that it's the doctors that are treating, but however, it's nurses that actually identify these subtle signs, as I mentioned, identify these small signs, and then they're able to call upon the experts to give in their input, and also at the end of the day, they will be able to help in carrying out the treatment plan you have mentioned. So I welcome Sister Cyanosed to take us through.
Well, thank you, Dr. Edbert. Good evening, good afternoon once again. My name is Stella Athieno. I'm a registered midwife and a neonatal nurse at Kampala Hospital. I am going to take us through the nursing care that we will give to a Cyanosed newborn. So the introduction, cyanosis is a bluish discoloration of the skin and mucous membranes resulting from the inadequate amount of oxygen in blood. And many cardiac defects cause poor oxygenation, leading to cyanosis. Therefore, early and appropriate nursing care improves survival, reduces complications, and supports both the infant and the family. So we are going to manage this patient using the nursing process. This is the assessment, the subjective data. This could be the report from the mother. She gives reports of fatigue, maybe while baby is breastfeeding. There is exertional dyspnea. This is the difficulty in breathing, like after a brief activity like breastfeeding. Then objective data, there is weak peripheral pulses, and the capillary refill is usually slow, that is greater than 3 seconds. There is tachypnea of greater than 60 breaths per minute, low blood pressures, and if you assess for fluid balance and weight gain. And next is we are going to give the diagnosis according to our assessment. There is decreased cardiac output that is related to structural heart defect, as evidenced by weak peripheral pulses, tachypnea, and cyanosis, which were common elements in this particular case. And what is our desired goal? This newborn will demonstrate improved cardiac output and peripheral perfusion, as evidenced by stronger palpable pulses. The BPs will be between the normal ranges, that is 60/45 millimeters of mercury, and the oxygen saturations are 75 to 85%. As you take note that this is in congenital heart disease, that is the target, and if it is in the normal newborn, our target would be between 90% to 95%, and there will be urine output that is equivalent to 1 ml per kg per hour within 4 hours. The interventions, you monitor the vital signs, including the heart rate that we said should be between 120 to 160 beats per minute, The respiratory rate, that is 60 breaths between 40 to 60 breaths per minute. The oxygen saturations, the BPs are monitored every 2 hours. The next, you administer oxygen as prescribed, preferably could be by CPAP. Then monitor the fluid balance and document accurately and timely. Then administer cardiac medicines as prescribed. For example, if they prescribed prostaglandin E1, so you administer. Then what will be the rationale of the interventions? For monitoring vital signs, it helps us to detect any abnormalities and prevent complications. Why would we administer oxygen? Oxygen reduces hypoxia and workload on the heart. Why do we monitor the fluids balance? To avoid any fluid overload that would worsen the condition. Why would we administer the cardiac medicines? These medications help to maintain the ductus patent in case of the ductal-dependent heart defect. What is the evaluation? The peripheral pulses will improve within 4 hours, and the capillary refill time within the normal limits, that's less than 3 seconds. The next assessment, the next nursing diagnosis would be impaired gas exchange that is related to altered blood flow pattern as evidenced by central cyanosis. That is, there is also low oxygen saturations. Like in this particular case, our baby had oxygen saturations of 71%, and there is also tachypnea, difficulty in breathing. And our assessment, mother reported baby was breathing fast. There was poor feeding, that was interrupted breastfeeding. And the objective data, the central cyanosis, low oxygen levels, tachypnea, and irritability. What is the intervention that you would do as a nurse? I beg your pardon. The expected goal, the newborn will demonstrate improved respiratory status with a respiratory rate of 40 to 60 breaths per minute, and the oxygen levels will be within a target range of 75 to 85% within a range of 1 hour. What are the implementations that we are going to do to achieve our desired goal? We administer oxygen as ordered. For example, in this particular case, oxygen was given by CPAP. And what is the rationale? Oxygen helps to improve circulations, but administer oxygen with care that there is possibility of oxygen worsening some congenital heart defect lesions. The other intervention is cluster care and practice minimal handling. This is like you're going to draw a sample of blood, you're going to change the diaper, so do all those procedures within a given time. This helps to allow rest to the baby, which lowers oxygen demands. Next intervention would be positioning the baby in St. Paula's position, that is raising the head at the bed at an angle of 30 degrees. It helps to enhance lung expansion. We are also supposed to maintain a neutral temperature, as this is important because both cold and warm extremes, they increase the oxygen demands of the body. As we know, the normal temperature that we want to achieve is between 36.5 degrees Celsius to 37.5. So what would be our evaluation? Oxygen saturation levels remain maintained within the prescribed targets of 1 hour. That's the 75 to 85%. Yes. The next nursing diagnosis would be activity intolerance related to imbalance between oxygen supply and demand, as evidenced by poor feeding. And assessment, there is interrupted breastfeeding, as in this particular case, the mother reported baby wasn't breastfeeding well. There is fatigue, that is sweating while breastfeeding. And objective data, there is tachypnea, there is cyanosis, there is tachycardia, that's a heart rate of above 160 beats per minute. There is low oxygen saturation during exertion, that is during minimal exertion, for example, during breastfeeding. What is the desired goal as we take care of this baby? This newborn will show improved feeding efficiency that is demonstrated by fewer interruptions during breastfeeding by the end of the shift. And how would we achieve this? Through monitoring the oxygen saturations, respiration rates during and after activity, that is preferably after breastfeeding, and document timely. And also, the rationale, it helps to detect early signs of intolerance, like tachypnea. And also, the other intervention would be to give small feeds frequently or feed via NG tube if possible. The rationale is to allow rest, which helps to decrease the metabolic rate, hence lower the oxygen demands. And the next desired goal, I remember we'll have to include the family as they take care of the baby to help them cope with the situation. So another desired goal would be the parent will verbalize at least 2 energy conservation techniques by the time of discharge, that is clustering care and positioning the newborn. So how are we going to do this? The intervention will assist the parents to plan for care of the newborn and also rest schedules. What is the rationale? It helps to prevent overexertion and conserves energy. Then evaluation, the newborn will appear less fatigued with decreased tachypnea by the end of the shift. The other nursing diagnosis would be risk for infection related to invasive procedures like IV lines or inadequate primary defenses. So our subjective data, like in this particular case, the mother had prolonged drainage of liquor that was 14 days prior to delivery. So there is history of prolonged rupture of membranes that predisposes the baby to infection. Then objective data, there is cyanosis, there is difficulty in tachypnea, there is low oxygen saturations, and presence of invasive lines like an IV line. What is our desired goal here? The newborn will remain afebrile within normal temperature limits, that is 36.5 degrees Celsius to 37.5 throughout hospital stay. Interventions, how are we going to do this, to achieve this? Through monitoring the vital signs, including temperatures every 2 hours. How is it important? The rationale, it helps in early detection of abnormal temperatures, which will help in identifying infection promptly. And the next intervention, you have to wash hands and maintain aseptic techniques before and after handling the newborn. This helps. What's the rationale? Hand hygiene is the most effective method of reducing infections. The other intervention would be administering antibiotics as ordered. It helps in eliminating the underlying bacterial infection. How do we evaluate this? The newborn remains febrile with normal temperature ranges between 36 to 37.5 during hospitalization. Yes, and those are the references for the presentation. Thank you for listening.
I think I'd say a round of applause to our midwife and nurse of the day. Thank you very much, Sister Stella Atieno. It was such a wonderful presentation. I'm very sure that we have to realize that nurses and midwives do a very, very big role when it comes to management of our babies, newborns, and actually all other patients in general. So in case you are there and you have picked up something, some interest, and you wish for more elaboration from our sister, you can raise it up. And kindly also remember to always to follow Seed Global Health and on X, and then on YouTube, then plus the website, so that you can actually pick all these previous recordings that have been presented prior to this one, and also even this one will also be shared there. So that if you want the presentation, you always find it there on the website. Since someone was requesting for the slides to be shared on their email, don't worry, they will be shared on the website, and you always find them there. Even the previous sessions are already there. Then I've seen Dr. Dora has been answering most of the questions on chat. I don't know if there's any question that requires more attention before we dive into the senior expert who is with us, Dr. I'm not seeing any. For now, let me call upon Dr. Dora Nabija, who is online. If maybe there's anything you wish to elaborate more on among the questions which have been asked, kindly you can air them out and maybe elaborate more.
No, I think we are good. Let's wait for the expert presentation. Maybe that's we shall get more questions. I'll try to answer other questions in the chat, and they can keep the questions coming, and we shall answer them.
Yes, thank you very much, Dr. Dora, for that. And for now, let us pray our brains and be ready for all the knowledge you wish to know about cyanotic baby from our expert of the day. He has already introduced himself, but I feel like he did put it out there. He's big enough to answer any question, but and I have much trust in him. Doctor, you're welcome.
Thank you very much, dear moderator, Dr. Edbert. I'd already introduced myself. So I'll be taking through a management approach to the newborn who presents with cyanosis at all the different levels of care you may be based on. As you realized from the previous presenter, that there is a lot that you can do for a newborn who presents to you with cyanosis. We've already gone through this, that cyanosis is a bluish discoloration of the skin and mucous membranes, which is because of increased accumulation of deoxygenated hemoglobin. The key thing there is that the level of hemoglobin will determine the level you'll get cyanosis at. If you have polycythemia, lots of hemoglobin, like many newborns have, then small degrees of desaturation or higher SPO levels could actually cause you to have cyanosis simply because you have a lot of hemoglobin, you're polycythemic. On the other hand, if you are anemic, if a baby is born and they have anemia from whatever cause, then it will take a lot of desaturation for your SpO2 to be so low that you can actually have clinically evident cyanosis. It's always important to evaluate these children urgently because the brain, which is the main driver of every other function, is dependent on oxygen. So if you have a baby with cyanosis, you need to rapidly evaluate them and know what they could be having as in a possible diagnosis. For you to maintain normal oxygen levels, there are certain things which must work together. You must first take in inspired oxygen. That inspired oxygen must be able to reach the alveolar capillary units. For you to be able to do that, you need to have adequate respiration or ventilation. And deoxygenated blood, which is coming from the systemic circulation, should be able to return to the lungs so that they can pick the oxygen. And you hope that in your lungs, in the alveoli, the oxygen is able to diffuse from the alveolar spaces to the capillary blood. After diffusing, that oxygen must be able to bind to hemoglobin in the red cells which are passing through the pulmonary capillaries. After the pulmonary capillaries have collected this oxygen, then all that blood, that oxygenated blood, should be able to return to the left heart and then be pumped into the systemic circulation. You also hope that when it reaches the systemic circulation, there's not too much oxygen extraction. So if you remove so much oxygen from that blood, then you could actually have desaturation there. So this is a summary figure. I think we've had this figure since primary school, but it is very basic, but it explains also a lot to what could cause cyanosis. So anything which prevents airflow going to the lungs, whether it is at the level of the airways, it could potentially cause cyanosis. Anything which interferes with the diffusion of oxygen into the capillary will potentially cause cyanosis. Anything which interrupts the expansion of the lungs, expansion of the alveoli, could potentially cause cyanosis. And if you don't get deoxygenated blood passing through those capillaries for one reason or another, you potentially can have cyanosis. So what is the pathophysiology like in summary? In summary, there are so many things which can cause a newborn to have cyanosis, and it is important for health workers to pay attention to all these things. By and large, the most common causes are ventilation problems and perfusion problems. So ventilation, you have something in the airway or the lungs that prevent oxygen going into that alveoli. This one, of course, will eventually lead to low partial pressure of oxygen. And then perfusion problems. If your deoxygenated blood from the rest of the circulation is not entering the pulmonary capillary bed because of right to left shunts, because of mixing, then you will end up with cyanosis. Very rarely that hemoglobin may exist in a form in which it cannot pick oxygen. So yes, you have hemoglobin, but it has iron 3 instead of the normal iron 2. That is called methemoglobinemia. Cannot carry oxygen. That can happen because of a number of reasons, whether congenital defects or exposure to certain chemicals by the mother. So the hemoglobin is there, but it cannot carry oxygen because the iron is in a different state. Or you have neuromuscular problems. For you to breathe, we need a well-working central nervous system, which controls the respiratory drive. So if you have things like apnea of prematurity, you have CNS infections, meningitis, neonatal meningitis, or you have intraventricular hemorrhage, or you have HIA, birth asphyxia, hypoxic ischemic encephalopathy. It will impair your respiratory drive. Or if you have muscular problems like hypotonia, generalized hypotonia, you can have impairment in your ventilation and cyanosis. So in summary, these are the common causes that we see of cyanosis in the newborn. Respiratory causes, respiratory distress syndrome, pneumonia, meconium aspiration, transient tachypnea of the newborn, persistent pulmonary hypertension of the newborn. If you have any congenital airway or lung malformations, all this will impair your gaseous exchange and contribute to cyanosis. And then the cardiac causes, the 5 T's, I think many of us, the medical people, we know. Transposition of the great arteries. If a newborn presents with cyanosis and you think it is cardiac, we're going to talk about it. Transposition of the great arteries is a common one. Then tetralogy of Fallot across all its varied spectrum. Tricuspid atresia, total anomalous pulmonary venous return. I say that the oxygen in the capillaries must return to the left. Now in total anomalous pulmonary venous return, instead it returns to the right side of the heart and mixes. So even if your oxygenation is very, very normal, but because the veins are going somewhere else, you end up with cyanosis. We've talked about methemoglobinemia, we talk about polycythemia. And also gastrointestinal tract problems can present with cyanosis. For example, esophageal atresia, tracheoesophageal fistula. If you have a connection between the airway and the food pathway, you can obstruct the airway. Typically, they have a lot of secretions in the mouth. Oxygen can't diffuse, and then you end up with cyanosis. Congenital diaphragmatic hernia. These children typically will come with severe respiratory distress, cyanosis. The abdomen will be scaphoid. The abdomen will be empty. It's like you've starved the baby for so long. You think you should always suspect congenital diaphragmatic hernia. And then various central nervous system and neuromuscular problems. Of course, hypothermia, a cold baby. If your baby is cold, you're going to have peripheral vasoconstriction. Once that happens, you will deliver little oxygen through the arterial system, and the body will extract so much of it to the point that you will get cyanosis, peripheral cyanosis. So what are the patterns? And the patterns of cyanosis can help you narrow down the differential diagnosis. Central cyanosis is cyanosis which affects both the mucous membranes and the skin, like in this case that we had. Peripheral cyanosis, on the other hand, involves only extremities, and newborns typically can have this because of problems with their vasomotor control. They typically will have this, and I think I'm going to show you some pictures. Differential cyanosis is where only the lower limbs are cyanosed. So the lower limbs appear blue or purplish, and the upper limbs are nice and pink. Then occasionally, very rarely, you can have what we call reverse differential cyanosis, where the upper limbs are cyanosed, but the lower limbs are nice and pink. This is, in summary, what I've been saying. The panel on the right of the screen is where we have differential cyanosis. The lower limbs are blue, the upper limbs are red. In the middle, you have the upper limbs are blue, the lower limbs are red. This is reverse differential cyanosis. Somebody mentioned something about coarctation of the aorta in the questions. Coarctation of the aorta. If it is critical coarctation of the aorta, which is duct dependent, that means the aorta is so narrow, the peripheries are being perfused only through the PDA or the duct. Then you can have mixing of both blue and red blood. It will appear purplish. This is typically how coarctation of the aorta will present, or diseases associated with obstruction to systemic outflow. I get called, as a pediatric cardiologist, I get called so much for this problem, which is called acrocyanosis, where you have the hands and the feet being pink. If you have only, being blue, cyanosis only in the feet and the hands, but in the rest of the body, the baby is nice and pink. Yeah. This is acrocyanosis. It is benign. Probably the best thing you need to do is just to observe. Usually it will resolve in 24 to 48 hours. Keep your baby nice and warm and clean. You will be able to solve that problem. So this picture, shows the progression. It's the same baby, just 24 hours later. The last picture on the right. So this baby didn't need to be checked in the heart. So when we are doing evaluation, when you are assessing a baby who presents to you with cyanosis, it's important that you take relevant history, and typically we'll get a lot of clues from the history. For example, how did the pregnancy go? Were there any abnormalities detected in pregnancy? Did the mother, for example, have an infection in pregnancy? For those countries where they're able to do screening for group B streptococcus, was it positive or negative? Because sepsis, which affects problems with the peripheral vasoconstriction and so on, can present, or even shock, can present with cyanosis. So that history is very important. The history around delivery mode is extremely important. It's extremely important to know, was this a cesarean section? Was it a normal delivery? Because cesarean section, they can have transient tachypnea of the newborn, impaired gaseous exchange, and cyanosis. So that's important. Apnea of prematurity, we have talked about it. Our patient had a prolonged rupture of membranes before delivery. This predisposes to sepsis. If they have prolonged labor before delivery, there are two things: meconium aspiration. So meconium aspiration can present with respiratory distress and cyanosis. So all that is important. And then the APGAR score, of course, will tell you. When you assess them physically, look out for signs of severe respiratory distress, increased work of breathing, grunting, chest retractions, whether they are suprasternal or they are xiphoid or intercostal retractions. It's very important. Of course, you have to look out for the pattern of cyanosis. We've told you already how the pattern of cyanosis helps you to narrow the differential diagnosis. And then you do a detailed respiratory exam. But particularly pay attention to the work of breathing, the features of severe respiratory distress. If there's severe respiratory distress, marked retraction, grunting, it's most likely a respiratory cause of cyanosis. We do a detailed cardiovascular exam because those two are the most common causes. How are your pulses? Are the peripheries warm? Like in our patient here, the peripheries were warm, so it excluded obstructive lesions, like coarctation, interrupted arch, and so on. How is the pulse volume? Is it small volume or large volume? How is the precordial examination? Heart sounds. Someone asked about, can't you tell transposition of the great arteries on the physical exam? Yes, you can tell. So typically transposition of the great arteries, apart from the baby being cyanosed all through, having central cyanosis, these babies' heart sounds are usually typical. The aorta in this condition is very anterior compared to usual. So the A2 will be very loud. Because the arteries are switched, usually they lie just on top of each other. So the second heart sound will be single and very loud because now the aorta is anterior. This is usually typical for detransposition of the great arteries. Of course, you may get heart murmurs. Our patient here had a heart murmur because of patent ductus arteriosus. There are very many cyanotic heart diseases where you will not get a heart murmur, but it's important to do a detailed CVS exam. And then the neuromuscular exam we've already talked about, apnea and CNS depression and generalized hypotonia causing cyanosis. Sorry. All right, so the diagnostic evaluation is important. You do a pre and post ductal saturations. This can help you narrow the diagnosis. Pre-ductal saturation is saturation in the right arm. Post-ductal saturation is saturation in the leg. Either foot is enough. You can measure that. In our baby, both the pre and post-ductal saturations were normal. So we know that there was not much right to left shunting across the PDA. That also helped narrow the diagnosis of transposition of the great arteries. Then you can do what we call a hyperoxia test. In a nutshell, you put the child under 100% oxygen, 100% oxygen. If you are able, you do ABG, the blood gas for partial pressure of oxygen. Typically, if the partial pressure of oxygen improves dramatically to more than 100 on hyperoxia tests on this 100% oxygen for 10 minutes, most likely that is respiratory. If you're not able to do a blood gas, just your pulse oximeter measurement. If your pulse oximeter measurements increase to 90 and above, dramatic improvement on oxygen, most likely this cyanosis is respiratory. If on the other hand, your saturations do not dramatically improve, they improve by less than 10% change in the pulse oximeter, or if you measure your partial pressure of oxygen, it is less than 100, then most likely this is cyanotic congenital heart disease. So two things. How it improves on oxygen is very important. And then you can do the other tests like the blood glucose. If babies are hypoglycemic, they can go into seizure or become unconscious, and their respiratory drive will be affected and they can become cyanosed. So blood glucose is very important. The septic markers are very important. After that, chest X-ray is very informative, and echocardiography, of course, to exclude congenital heart disease. We will not go through this a lot, but I thought I should mention this, that if the cyanosis you think most likely is congenital heart disease, in B, panel B is a baby who has differential cyanosis, where there is shunting of blood, left to right shunting of blood to the descending aorta. This typically, through the PDA, this typically happens in persistent pulmonary hypertension of the newborn. If the PA pressures are significantly elevated and the PDA is open, then the blood will shunt from right to left through the PDA, causing you to have desaturation in the leg while the arms remain well oxygenated. They remain pink. If you have a TGA with a PDA, if you have TGA with a PDA, like in our case, now the direction of shunting depends on how high the pulmonary artery pressures are. If they are very high, it will behave like PPHN. If the pulmonary pressures are very high, the legs will be desaturated, while the legs, if they have pulmonary hypertension with a TGA, you have reverse differential cyanosis. Why? Because in this TGA, the pulmonary artery is coming from the left atrium, which has oxygenated blood. Because the PA pressures are high, it will shunt through the duct to the leg. So the leg will be much more pink compared with the arms in TGA with pulmonary hypertension. This is just one example of reverse differential cyanosis. And then if they don't have pulmonary hypertension, it will be just a blue baby, like was in this case that we presented. The chest X-ray is very important to tell. The chest X-ray. If you have a chest X-ray which appears like ground glass, as in preterm baby, most like, and you have hyperinflation. Remember the hyperinflation, the respiratory distress is trying to compensate for the ventilation problems. This is most likely respiratory. And there are so many other X-rays you will have shown, but I just chose these two because these are the very common ones we see. So meconium aspiration syndrome, usually they will have fluffy opacities in the lung. That will tell you this is definitely meconium aspiration. For cardiac, on the X-ray, the common, like in TGA, we see what we call an egg on a side appearance in transposition of the great arteries. Egg on a side or egg on a string. The string is because the aorta and the pulmonary artery overlie each other. So your mediastinum is very narrow, like a string. Yeah? This is what we call an egg on a string appearance. That will be transposition of the great arteries. If, on the other hand, you have something looking abnormal like this one, and your saturations are not improving on oxygen, this is supracardiac TAPVRI, what we call a snowman sign. So what can you do before you refer these patients at your sites? It's important that you stabilize the airways. So ABCs, airway, breathing, and circulation. This may include suctioning, back mass ventilation, putting an IV line, IV access, some IV fluids if they were dehydrated. Remember, when they're breathing so badly, they easily get dehydrated. They can have gas, electrolyte and gas abnormalities. So it's important to stabilize the ABCs. Keep them warm and clean. The warmth is because if they are hypothermic or hyperthermic, it increases the oxygen requirements. So their cyanosis will worsen. You keep them clean so that they don't get sepsis. You give supplemental oxygen as per requirements. If a baby was cyanosed at 60% and you give a little bit of oxygen and the cyanosis is 90%, 100%, then you optimize the oxygen. Most likely that is respiratory cause of cyanosis. And depending on where you are, you can have various modes of delivery of the oxygen. However, if the baby is cyanosed and you give your 100% oxygen and the pulse, the saturation don't improve much, most likely it is a cyanotic congenital heart disease. So in that case, you give as minimal as possible to reduce the work of breathing. Why? Will somebody ask a question, how oxygen may worsen some of the children who have cyanosis. If you have oxygen can constrict the duct. It is a stimulant for the PDA to close. Our baby here is still surviving now because he had a moderate to large PDA. It's open. God made it that way. But if you give 100% oxygen, this PDA can close with that oxygen. And if it was a duct-dependent lesion, whether it's duct-dependent pulmonary circulation like pulmonary atresia, you are basically closing off that child's lifeline. So you are doing more harm. The saturations will drop further. If On the other hand, the child has left to right shunt, and it is causing pulmonary overcirculation or pulmonary edema. Oxygen can cause pulmonary vasodilatation. It can cause flooding of the lungs. And unfortunately, these children will worsen with heart failure, will worsen with increased work of breathing because of pulmonary edema. So it's very important to determine whether this child needs oxygen or not. If they don't need oxygen, just very little. Ensure feeding, we have talked about it, antibiotics, we've talked about the pre and postductal SpO2 measurements, counseling and education. And then if the child doesn't improve on whatever you've done so far, you need to refer this patient. It's good courtesy that you consult the patient, the doctor at the referral facility and ask, there's this baby, I would like to refer to you. I've already done A, B, C, D, they are not better. This helps us to plan to receive you, or the next level of care receives you. Next, please. Sorry. So where can you get help if you need echo? Put here different districts where you can get help. Unfortunately, you can see that the majority of the country is not covered. The majority of the country is not covered. We need to do a lot more, but as I've said, you can already do so much more. This patient came all the way from Balala, from Mukono to Kayunga to Kawempe. You can see the distance and number of days lost. So you can get help from whether you're in Gulu or Lira or Soroti or Mbale or Jinja, Fort Porto, Mbarara, Masaka, Wakiso, you will get help. You just need to call. Those are where we have echo facilities. I know there are other forms which exist in other countries, but I cannot be able to verify the accuracy of those ones. So at the referral centers, if it's a regional referral hospital or a regional heart center, which we are going to do, you can do the pre and post ductal measurements, optimize ventilation according to requirements. You can do chest x-ray. If they have PPHN, then sildenafil. They can do screening echo at least before referral. Counseling is very important. And then you can consult also with your colleague in the next level of care. Eventually, most of these children with cyanotic heart diseases will come at the Uganda Heart Institute. What are we able to do there? We can give them echocardiography. We can do the final diagnosis to plan what we can do for them. Of course, you can start dinoproston. It's like prostaglandin E1. We don't have prostaglandin E1 to maintain the duct open. We use this oral prostaglandin, which our friends in maternity use it a lot. But we can use it for babies to keep the duct open so that at least you maintain perfusion or mixing. And then we're able to do counseling for parents on what is needed. It is important, and my colleagues requested me kindly, for those in Uganda, that before you refer patients, kindly reach out to us. I'll give you the story of this baby we've discussed. This baby came on Monday evening at around 4 p.m. When you are winding the day, now you are giving a mother a very big diagnosis at the end of that day. So the counseling is not so optimal. But if we had prepared before, and usually when they come late, then we have to, typically the children are on oxygen, so we prioritize them. Remember that there are also others who have been waiting, and it's the end of the day. So it gives us a lot of challenges. So we request our friends, our colleagues in Uganda, please kindly reach out to us by phone call so that we plan to receive you and we allocate resources to receive you. We can do for the interventional procedures immediately we can do at the Uganda Heart Institute is balloon arterioseptostomy for children who need it, and we're able to do it. Unfortunately, this mother, we have not been able to do. She's still lucky. I was able to reach out to them 2 days ago because of some family social circumstances. But we are still lucky that the child is alive because he has a large PDA. They are coming in on Monday, and I hope that I'll be able to schedule them for a procedure next week. So we are able to do balloon septostomies. Typically, we do about 5 in a year, because this majority of these children die in the community. But I want to tell our audience that we are able to do this, and sometimes at minimal cost, including zero cost, if we have a commitment from the parents that they accept the care we give them, we can give them at zero cost. And then hopefully in the next few months to years, we'll start doing PDA stunting, again to keep the PDA open, and then our surgeons can do a modified BT shunt. As I wind down, I'm sorry I've taken slightly longer, but as I wind down, you can screen for cyanotic congenital heart disease with a pulse oximeter before hospital discharge. As we say many times, these babies with the cyanotic heart diseases, they may even be breathing normally. Like our case had only a SAS score of 1. This one, we call it quiet tachypnea. So unless you screen for them, you will miss them, you will discharge them home. So just pulse oximeter screening in the right hand and in the right foot. If your saturations are more than 95%, that is a good case. Or if the difference between the two is less than 3, this is a good case. They can go home. If, however, the oxygen level is less than 90%, any level less than 90% needs you to refer to Uganda Heart Institute. Or if a difference of more than 3% between the upper limb and the lower limb, this one you need to send for us to review, even when the baby is breathing normally, as usually will be the case. And then, of course, to reduce false positives, you screen them when they are alert, not when they are sleeping, because when they are sleeping, their respiratory drive goes down. So their oxygen levels may actually go down. So screen them when they are alert. Screen them when they are more than 24 hours, usually typically before home discharge. Now they have adapted to the outside world. And when you have weaned them off, supplemental oxygen. I will not go through this thing, but this was just a summary. So finally, cyanosis in a newborn has varied etiology. You should be able to differentiate between pulmonary and cardiac causes. The pulmonary ones, as we said, they will improve dramatically on oxygen. Their saturations improve dramatically on oxygen, and they will have marked respiratory distress. Compared with the cardiac ones, they will not improve so much on oxygen, and also they will have minimal respiratory distress. They will be having quiet tachypnea. This one will be cardiac needs referral. And then the, of course, response to oxygen and chest x-ray. In our settings, we use dinoproston, can be life-saving, and then we need early coordinated care. Let's work together to improve the care of our newborns. I would like to report that from the beginning of this year, we have increased on the number of septostomies that we do. We are approaching 10 from 5 previously. It means that the screening is improving. From our calculations, we need to do about 100 in a year. So we're working at about 10%. So give us more business. Thank you very much.
I think he deserves a round of applause from us, and you can also send me flowers in case you feel like if you go online, you can send in flowers so that you can be sure that you have actually understood. Yes, thank you very much, Dr. Twalib. I'm very sure you have actually surpassed our expectations, and we are all happy to have learned and picked something from today's session. And I'm very sure that his presentation has touched not just doctors, not just nurses, has touched each and everyone across all the different cadres. As I mentioned, this session is to enable us to learn how to manage this patient, whether we're the midwife or whether we're the nurse who has just received this baby that has come in as a referral at your hospital, or you are the obstetrician who has delivered this baby and you are called in to review a baby that you have just delivered and is still blue. Because I know that we have an APGAR score where we always score the appearance, and we score the blue discoloration. So you find a sign midwife, and plus the doctor and everyone, they are giving oxygen, they're resuscitating, adding more oxygen so that the blue discoloration disappears. but yet failing to remember that blood discoloration is not just about oxygen insufficiency. There are very many things, as Dr. Twalib has mentioned. There are the four problems where it is ventilation, perfusion, hemoglobin, musculoskeletal. So that is a small summary we should always put up in our mind as we are there trying to resuscitate this baby with APGA of has failed to reach 10. In 10 minutes, is still at 9, you're adding oxygen, 20 minutes, you're still at 9, you're adding oxygen, you're increasing to CPAP, you're failing to realize that actually you're causing worse to your patient, because there are some conditions, as I have mentioned, that worsen with your increased perfusion of oxygen as you're giving it. So thank you very much, and I'm very sure we have still learned, and I kindly request if there's anything you wish to have clarified on. But in the meantime, there are very many questions that have been asked, and I've seen Dr. Dora has been answering most of them online, and but some few I would allow our presenter to answer if there's anything that she wants to elaborate more from among the few questions she has been seeing being shared on chat. So we can go back. I have seen that there's someone who asked about someone asked about the dose of sildenafil.
The dose of sildenafil is 0.5 to 2 milligrams per kilogram, 6 hourly.
Yes, that is it. Our doctor had replied that said that it's just dependent on the weight. So that is it in full. So if you're giving your drug of sildenafil, that is the dosage. And I think you know the indication, as Dr. Twalib has mentioned. So I'll allow our online expert, Dr. Dora, to mention something. And at the same time, if there's anything that our midwife has picked up and she wishes to share with our nurses and everyone on the call, to air them out. Anything?
Yeah, well, thank you, Dr. Hubert, for this opportunity once again. Oh yes, as Dr. Aliku has shared, I would like to elaborate more on the part of the nursing care as we manage this newborn, focusing on the airway, breathing, circulation as well, and the drugs. So as we are focusing on congenital heart disease, cyanotic, for this case, you don't forget the airway as well. That should be the beginning of the management of this baby, of this newborn. Make sure that the airway is patent. If there is any secretions, you suction them, you suction what you see. And positioning as well, like we said, in that the semifolars position is good in this case of the congenital heart disease. Yes, and documenting, and more so the oxygen circulations, the preductal and the postductal, that is the right hand and the foot either. In case of any abnormalities from the normal ranges, please escalate and inform the team. And also warmth, maintaining warmth is key in this management, and also involving the parents, counseling the mother, teaching her how to take care of the baby. Like in this case, after discharge, how is she going to manage this newborn? How is she going to be able to notice any changes? How is she going to manage the cyanosis? Thank you. Thank you.
Thank you very much, our midwife expert in the house. And I hope we have still learned something. Dr. Dora, kindly, yes, you're there.
I want to thank the audience for really logging in large numbers. And I've tried to answer many questions. One of the questions that probably came in last was the role of LASIK in this child. From the presentation, we didn't get to learn about what treatment was given at UHI. But most times the reason we give lazy to these children is to prevent and also treat volume overload. That lesion the child had was a lesion that was associated with increased pulmonary blood flow that would cause the child eventually to get overflood of the lungs and giving them features of heart failure and difficulty in breathing. So I believe among the treatments I was given was Lasix when they went to Heart Institute, and also some drugs, AC inhibitors that would prevent remodeling of the heart as we wait for surgery, and also the palliative, the bridge surgery that we are planning to do next week. I don't know if there are any other questions that I've not touched on. Maybe some were beyond me. Like try to answer on the fluid balance chart, which was talked about by the midwife. And in newborns, really the fluid balance about knowing how much the child has taken in through breastfeeding, any IV treatments, maybe detain the drugs, and balance them, and also looking at how much urine output gets out. In advanced places, they kind of weigh the pamper, how heavy it is after every day, also monitoring the weight, how the child is either losing weight or gaining weight, which is also one way we know if the child is retaining fluid and getting into heart failure. I don't know if there are any other questions that I'm seeing new questions. Yeah. So about the dose of sildenafil, I had put the initial dose. It's an incremental dose. You usually start between 0.5 per kilogram every 6 hours, and you continue titrating upwards until you get the desired outcome. And the sildenafil is mostly used for pulmonary hypertension that comes as a result of cardiac disease or any other cause of pulmonary hypertension. I think that is all that I have to say. Just to thank us for the audience has really been a big turn. Thank you.
Thank you very much, our chat expert, for that. And I believe she has done a very wonderful job at her station where she is, answering most of the questions and in time. And I encourage that if you still have any more questions and you feel like should be aired out, kindly raise up your hand, and you can raise up your hand, and then we shall allow you to unmute, and then you can communicate to us. In the meantime, our expert wants to add something small.
Yes. Thank you, moderator. I think I just wanted to say something small. So sometimes it's very important to know when the baby gets cyanosed. If it's not there all the time, when does the baby get cyanosed? Sometimes the baby gets cyanosed when they are crying. So if they are crying, the cyanosis gets worse. That's usually most likely respiratory, but also we know that cyanotic heart disease, especially with increased pulmonary blood flow, will also come like that. The cyanosis gets worse with crying. But there are conditions where you have cyanosis at rest, but when the baby cries, the cyanosis improves. This is very rare, but it can happen when a baby is quietly sleeping, is more dark or more blue, and then when the baby starts to cry or feed, when the baby starts to cry, then they get better. This typically happens with the choanal atresia. With choanal atresia, it's a very good clue to ask when the baby gets cyanosed. So they typically will get cyanosed while they are at rest or when they are sucking, because babies are obligate nasal breathers. They only can breathe through the mouth, through the nose. So if they have problems with their nose and then you are also blocking the mouth, then the baby will get more cyanosed. I thought I should tell you this small trick. It is called paradoxical cyclical cyanosis. It's paradoxical because most of the time people get cyanosed when they are crying. But this one is paradoxical in that the cyanosis improves with what? With crying. Yes, that's typically points to choanal atresia. Yes, thank you.
Thank you very much. I am very sure we have picked up a new terminology right now. Maybe some of you knew it, but maybe not. That is a wonderful addition to my vocabulary, and I'm very sure one day we'll be diagnosed that. So once again, thank you, presenter. In case there are any questions, I kindly request you to raise up your hand. Anyone that wishes to ask a question. By the way, it's not basically, you should not focus only on the heart. There could be a question you feel like you picked up along the way. That's not basically about this, but we have our experts around. So please ask anything you wish to ask about a pediatric, a baby, a newborn. I saw someone asking about jaundice. If Dr. Ferguson asking about jaundice, how sunlight works. And yeah, I think it has been answered about the use of use of sunlight, morning and evening sunlight as a phototherapy in places where you don't have such phototherapy machines. Any other question will be very much welcome. Direct any of us. And I've seen, most of you asking about the CBD points. I'm very sure those will be worked upon by the technical team. None of us here on the panel may be able to answer that part, but I'm very sure they finally be rewarded in the due course of before the year ends or sometime. And also for today's session, the link will be also shared, and then you'll be able to log in, and they will be sent to you in the due time. So don't be worried. It's okay to attend the session and to pick knowledge and at the same time to pick the points. Yes, so I think I'm not seeing, okay, I'm seeing that there are more questions being run in the chat. Any that you need more clarification, I wish you could raise up your hand. Or if you feel like there's anything that you need to even inform us, you can find they have a case which is unique at your place there. And if you feel like you can actually share it with us, so you're very much welcome. We still have our time. We're still on time, so anything is very much welcome. And okay, please talk more about TTN in newborns. I think our expert can work on that.
All right. TTN is called an abbreviation for transient tachypnea of the newborn. This typically we see it in babies who have been delivered through cesarean section, especially elective, majorly elective, and even the emergency ones. The reason is that they have retention of fluid in the lungs. When babies go through the process of labor, the compressions, they have to go through the birth canal. Somehow the fluid in the lungs gets expelled. That's why you have to do a lot of suctioning when babies are born. But in babies who are born, especially through cesarean section, they can have retention of that fluid within the lungs. They have not had an opportunity to expel it. So what does it happen? What does it cause? It causes problems with the oxygen diffusing into your capillaries. So babies will feel like, remember it is fluid. So you feel like you're drowning in your own fluid. And this is why they have difficulty in breathing. Typically, it says if just a few moments after birth. But the good thing is that as the hours go by, the baby's own body absorbs this fluid and eventually they pass it out in the urine. And so the natural history is that typically it will get better in the next 24 to 48 hours. Majority by 36 hours, they have gotten better. So what do you need to do there? Supplemental oxygen. Supplemental oxygen. I just want to say something about the PPHN as well, that this is a diagnosis of exclusion, that you have to do so many tests and prove that they are not the cause of the respiratory distress and the cyanosis, X-rays, echoes, and so on. So if that is the case, typically these babies need a little more time on oxygen. They need a little more time on oxygen. Oxygen helps the pulmonary arteries to dilate, the pulmonary vasculature to dilate. That reduces the pressure, the pressures, and so it will reduce the right to left shunting. Of course, you can use sildenafil. This is where in the newborn, this is where it is indicated that you can use sildenafil to help reduce those pressures. Of course, you have to be careful that the babies do not become hypotensive. And they don't become hypotensive. This is just something to watch out for. For them, they need a little more time on oxygen. What I discovered is majority of our health facilities, especially, of course, oxygen is billed. If it's private, it's quite expensive. But they just need patience. Just patience, keep them clean, keep them warm, keep them on that oxygen, which maintains saturations above 95. Yeah, until their lungs adapt and the pressures reduce. And typically, these babies are able to go home without any more problems.
Thank you very much, Doctor, for that explanation. And I'm very grateful that you have been part of this panel. And as you have heard, not all our patients now need to be flown out to India for the small heart surgeries. They are available done at UHI. And if you go, you can contact Dr. Charlie for a good passage. I think so. So and if there's any other question that you need to ask, unfortunately, my phone is here. If you have any questions to ask, kindly raise up your hand.
The moderator, I think it would be nice if Dr. Alifu highlights on the services that are offered at Uganda Heart Institute in more detail, so that our audience can know the things that are done at the Uganda Heart Institute and be able to refer the children there. It will be important for people to know what is happening. Dr. Alifu.
Okay, thank you very much, Dr. Dora, for your help in moderating and answering many of the questions. I still see some questions coming in, so hopefully, Dr. Dora, you'll be able to respond to those ones. What can we do at the Uganda Heart Institute? At least we can be able to offer you definitive diagnosis that your baby or your child or any patient has this type of heart disease. Then we are able to also treat definitively the heart disease. We can do closed heart surgeries. Closed heart surgeries, these are either transcatheter, like I do. I'm also an interventional pediatric cardiologist. So any of the procedures that need transcatheter care, like septostomy, like in this baby, like valve dilatations, pulmonary valve and aortic valve, like PDA closures. So in the cath lab without surgery, we can do that. Stenting the coarctation of the aorta, we can be able to do that, stent or dilate coarctation of the aorta without surgery. These are closed heart. Of course, there are also closed hearts that our surgeons can do. The open hearts, we can do really very varied, depending on your ASD, VSD, tetralogy, complete canal, TAPVR. These ones our surgeons are able to do them now at the Uganda Heart Institute, which is really 90% of the congenital disease burden we can do. Of course, there are those which are complex, which even in many centers will be palliation. Those ones we are not yet able to do. But 90%. So what is the message that we can operate on these children? Let us work together and counsel the mother that help can be found. And our department and our institute does not want any baby with certain diseases, any child with certain diseases to die in this country. That if you have a baby who has patent ductus arteriosus, you should not die. we can use every resource to operate that baby when that baby reaches Heart Institute. ASD, coarctation of the aorta. Any baby with those conditions will operate. So please, VSD is a little more complex, tetralogy is a little more complex. We have mechanisms to make sure this babies access care. So what am I saying? At least let the baby reach the Heart Institute, encourage the parents to keep coming if they're not yet operated, because if they don't come, we sort of lose touch with them and we may not be able to prioritize them. But in a nutshell, really for children with heart disease, not only children, but adults with heart disease as well, we're able to operate more than 90% now of the cases.
Thank you very much, Mr. Twalib and Uganda Heart Institute. I'm seeing there's a question. Kindly reproject it. Yes. Dr. Adora has already answered it. So I think we have all learned something from today's session. It's not that we always have to tell these parents, these new mothers and these new parents that, oh, your child has a hole in the heart, there may be nothing to be done. There is something that can be done. But all this starts from you, the health worker that is with this patient, to be able to identify that actually there's something wrong with the heart or any other organ. And that's the only way we shall be able to identify a measure or a treatment measure. And they have also told the team, the experts have taught us what should be done before you already send these babies to Heart Institute, because you may, in the process of just sending these babies to Heart Institute, they may pass on along the way. So you, as the person at the pre-referral site, you should know what to do as your emergency first aid to this baby, this newborn, and then you refer in the rightful channels, as I told you, that it's better you always do a pre-referral call to inform them so they can prepare for such a baby. So I thank you very much, and I thank each and everyone who has attended today's session. Thank you, our team of experts here. I think we are due time to answer our pre-post test. I think we have all learned something. Yes, the website has been shared where all these resources are going to be placed. The presentation of today, all the previous presentations, and also even the video recordings are going to be uploaded on YouTube. So there's a post test. Please answer something. I'm very sure you have all learned something out of today's session, and there's going to be a very good improvement in our performance as of the last performance we had in the pre-test. So you can answer as we go on. And I think as you're answering, I will encourage our facilitators here to just give a closing remark per person. So, Mr. Pidjo, is the turn.
Thank you so much, Dr. Nwamanya, for moderating this session. And thank you so much to our audience for sparing your time and listening to a baby with cyanosis. My take-home message is it is very important to take a very detailed history, a very good history when you get a newborn, and also do a very good physical exam so that you can have high index of suspicion for the cyanotic congenital heart diseases, and also to rule out the respiratory causes of the cyanosis. Thank you.
Thank you very much. Don't forget, it's not always about the heart. Other things can cause cyanosis. Let me allow Stella.
Yes. Thank you, Doctor, for this opportunity. And thank you, our dear audience. And thanks to C Global for this opportunity for us to present and to learn together. Yes, my take home is as nursing care is key in helping to prevent further complications in sick newborns. For example, here in a Cyanosed Newborn, as the assessment here, as well as you receive the baby, as you take care of the baby in the nursery, wherever, a midwife who is receiving the baby are putting in mind the ABCs, maintaining the airway, the breathings, the circulations, and to help this baby to survive. Thank you.
Yes, thank you very much, Sister Stella, for that remark. And let me call upon our expert to give us a closing remark. As in the meantime, please answer the questions that are being displayed. If you cannot find them in your right lower corner of your screen, there's more icon. You tap on it, you go to quiz and answer. Yes, Dr. Ali.
Thank you, dear moderator and team from Hope and Seed Global Health. Thank you for having us come here. Such a pleasure to share with our colleagues both in the country and outside in the rest of the world. The newborn with the cyanosis should not be scaring. If you have a very good systematic approach, you should be able to care for this newborn. Majority of them actually will not need referral. You'll be able to care for them at your place. Just ensure that that you're able to differentiate the common causes, which is respiratory, from the cardiac causes, which are more life-threatening and need more advanced care. I think this will be what I'll say. Thank you very much.
Thank you very much, Doctor, for that closing remark. I'll call upon our chat expert to give us a closing remark. I'm very sure there may be more questions you have come across well on the chat and first on this side. It's okay, you can, the floor is yours, Dr. Dora.
Thank you so much. Thank you so much. That's all I can say. Thanks to Seed Global for making sure that we continue to learn and to make the information reach everyone. With that 20, we had, I think we had at one point 250 people on the chat, and that is, if we have to take that information, that means that we are talking about 250 children that will be saved in the event that they have cyanosis, because we've learned what to do. There are no other questions in the chat, just people asking about their CPDs, but I'm so glad for having been given the opportunity to answer the questions and participate in this education session. Thank you so much.
Thank you very much. You have had one of the hardest tasks, answering questions in and out, sideways. That's a very good, and thank you very much for your contribution. Personally, I take this pleasure to thank Seed Global Health for actually allowing us to be part of this team and also moderating this session. So the poster test is going on. I think we are. I think we can end it, and Dr. Olive can just take us through the answers and maybe the reasons for the correct answer. Okay, so we are going to end it, and then if you have not answered, sorry, but whatever answered is that's good enough. So Dr. Twalib, our expert, will finish up those questions, and then we may put it a day.
All right. We can start. So our first question was about a 2-hour-old infant who comes with cyanosis, and the pre and postductal oxygen levels were different. The correct answer there is actually persistent pulmonary hypertension of the newborn. And I think the majority of you got this answer correct in the post-test, simply because the preductal saturations are 85%. They are higher than the postductal, which is 72%. That means that there is right to left shunting across the ductus arteriosus, causing the desaturation in the lower limbs. So that was the answer: persistent pulmonary hypertension of the newborn. The second question is about a newborn who presents with respiratory distress cyanosis and a scaphoid abdomen. It means that the abdomen is empty. Why is it empty? Because the gut contents have gone somewhere and they are in the lungs and compressing the lungs and causing respiratory distress and cyanosis. So the correct answer there is the congenital diaphragmatic hernia, and I think the majority of you got this correct. The next question was about the third.
Yeah, yes, number 3. A 2-hour-old term would be.
Sorry, I'm not able to see there. But the correct answer there is giving the prostaglandin E1 infusion. Why? Because he has not responded to oxygen. So it is most likely going to be a cyanotic congenital heart disease. So for that one, we give prostaglandin E1 infusion, and the majority of you got it correct. Number 4.
Neonate presents with
This one, I think I spoke about it last, but this term neonate who gets better while crying, the cyanosis improves while crying, but worsens at rest or with breastfeeding. This is usually choanoatresia. And most of you got the correct answer, that one. Either you put nasal airway if it is unilateral, but also positioning helps improve the cyanosis. So the correct answer there is nasal airway or prone positioning, which majority of you have got correct. Thank you very much that the correct answers were got by the majority.
Yes, that's very amazing and very good. Thank you very much, all of you, for taking part in this session. And at this moment, I encourage each and everyone to turn on your videos so that we can look at each other and say hi, wave to each other, and then we can close the day. I'm encouraging all of us to turn on our videos. Dr. Sapia Ronald, turn on your video. Yes. Can you turn on your videos? I hope you are seeing. Okay. That's good. Okay. Dr. Innocento, we are seeing you. Good. Dr. Asio Teopista. Amazing. Kindly, all of us turn on. Let's say hi to each other. Thank you wherever you are. I'm very sure I've learned something, you have picked something, and you're going to be able to apply this on your next babies that you're going to manage. Afande Maximilian. Oh, yes. I'm very sure that each and every one of us here will always apply this information that you have picked from today's session, and we shall have a better outcome of our babies who are cyanotic or even all other conditions. Let's always think about the baby as a whole, not just as like a small entity. Blue, let me give oxygen. Many things are going wrong there. And these babies always have subtle signs that you may not be able to identify if you're not able to understand what is wrong. Actually, lastly, I will know that they say that the eye sees what it knows. So if you don't know the effect of this cyanosis of this baby, you may never identify that this baby has some underlying disease that you're not following on. So thank you all of you for sparing today your time. Thank you for being available today, and yeah.
Merry Christmas.
And a Merry Christmas.
Merry Christmas.
And a Happy New Year. Yes. Thank you.